Welcome back to OpenLine. Thank you for joining us tonight. We are talking about the status of rural hospitals in Tennessee and why Tennessee is leading the nation in closures of those rural hospitals. Two wonderful experts joining me tonight to help us sort through all of this. Michele Johnson, Executive Director of the Tennessee Justice Center, and also Rebecca Jolley, Executive Director of the Rural Health Association. Thank you all for taking time to be here tonight. We have talked a lot about the status of where we are right now, how we got to this point. Is it realistic to think that we can reverse this trend, or is there going to have to be a new way going forward?
Well, in states that expanded Medicaid, and as Rebecca said, there's many issues in addition to that, but at states that expanded Medicaid, if you look at the uncompensated care numbers in those communities versus ours, and hospitals like HCA who have hospitals in states that expanded and didn't expand, they see dramatic declines in uncompensated care, just dramatic declines.
Explain the definition of uncompensated care.
So if someone goes to an emergency room because they're at risk of losing life or limb, then the hospital has to take them. And if that person then has no money, a CAT scan, for instance, could cost $5,000. If their waitress says they don't have $5,000, so that money is uncompensated. The hospital, like any other business,
has to eat it.
They have to eat it, and their way of figuring out how they keep the doors open has involved them passing that on to other insurers. So the insured folks would pay higher prices for their care because this person doesn't have any money. Now, if you need chemotherapy, and you go to the emergency room, you don't get that. So there are people, I think there's some confusion that if you need something, the hospital has to give it to you. That's not true. You have to get very, very, very sick before the hospital has to take care of you. And so having done this for 25 years, I can tell you every month we talk to somebody who's uninsured, who needs something that would save their life, but they can't get it. And they can't get it because they don't have insurance. And so yes, I think that we can reverse the trend if we have elected officials who say we want to expand Medicaid. We have lots of other issues that need to be fixed, and bringing more jobs to rural Tennessee is vitally important. Reversing the trend in terms of employer-sponsored coverage, even across the country, urban and rural, we have employers who don't provide employer-sponsored coverage, and that's been shifting for about 40 years. But the easiest, fastest way to slow this down so that we can start to fix some of these more complicated issues is to go ahead and take the $1.4 billion that's sitting in Washington and bring it to Tennessee.
Aside from doing that, will this change?
It will get worse. There's 15 hospitals in Tennessee, and so there are 15 hospitals at risk of closing imminently. And as I said, these are they're in communities that are already devastated. So if you happen to be driving in rural West Tennessee or driving in rural East Tennessee and you have an accident, there's a domino thing happening where there are 20 counties where you just can't get to a hospital.
I also wonder about the level of care in these rural areas and if that is impacting the closure, because oftentimes, I think this has come, as you all have seen, the experts flock to the metropolises, the Nashvilles, the Knoxvilles, the Memphis, and that's where you're going to go. If you're in an accident, you're going to have to get there.
Well, first you're going to have to be stabilized and then get to the best hospital. And so, as Marie said, they're definitely, figuring out how you set up a model of care where you can deal with the emergency and then get the person to the best and the brightest. But lots of people don't need the best and the brightest.
So does the business model need to change in these rural hospitals? They don't need to offer the 10 pages of services. They need to offer the emergency care and get them on. Will that change the bottom line?
That's one of the things that we have as an advocacy organization, along with the American Hospital Association, just been looking at for the past, decade now, is redefining the H, is how we call it. And what's the what? What do we need to have in our rural areas in order to provide exactly what you just said? The emergency treatment, the triage center.
Right.
Because right now what's happening is it's happening in the back of an emergency
ambulance
with EMS providers that are self-protested over their head.
Sure.
And triaging and trying to stabilize and trying to determine where to go.
Yeah.
And it shouldn't be on their shoulders. And we've placed it on their shoulders as a end all be all, just because they're the treatment of last resort. But when you look at what we've done on the national level and on the state level of looking across the landscape and saying what is working, what's not working, where do we need to be. I think that all of us in healthcare, we have recognized that there has been a dramatic decrease in need for inpatient beds. However, when you define a hospital, it's defined upon inpatient beds. So we have had an in-depth conversation with CMS, the Centers for Medicare and Medicaid Services, on redefining what that might look like and what is the next step forward. And I think that is an open conversation, and that's imperative because we have to be on the front edge of redefining that, just because we're also on the epicenter of closures. So I think that you're going to look at Tennessee as a nucleus for transformation.
Are there any counties that are figuring it out, who are making their way, or is everyone kind of drowning as we talk?
I have to celebrate our Senator Bo Watson. He, in 2017, passed a very vital and important piece of legislation for our state, the Rural Hospital Transformation Act. And having served on the advisory council since the formation of that act, I have seen firsthand some of the truly transformative conversation that's happening within our state and translating into our state legislature as it relates to just looking at what is the element of care that needs to exist in our rural areas, what can our rural areas support, and what do they need. We don't need to burden them with paying taxes to support something that's outsized of their immediate needs. So I love that piece of legislation just because it looks at spending state resources in a very valuable way of determining what are the next steps. Where do we need to be going? Where is the puck going?
Michele, when you think of next steps, even without Medicaid expansion, what can be some valuable next steps that can make a difference?
I mean, I think there are lots of valuable steps that make a lot of sense. It's just funding it in a state that is as poor as ours. So we have no income tax. We have one of the most regressive taxes in the nation. It's based on sales tax. And so when the economy is doing okay, we got lots of bachelorettes coming to Nashville. We have more money. If there's a recession, which sounds like might be soon, then the sales tax dollars are smaller. And so there's lots of exciting ideas about what might work. We don't have a state that can fund it, and that's why the expansion is it's free money. That's why it feels.
Can you explain that? Because I think that it just gets so muddy and so confusing when we talk about the Affordable Health Care Act, when we talk about Medicaid expansion. It just gets gray. Let's get back to the basics.
Right.
What are we talking about? Where did Tennessee miss out?
Yeah. So basically, the Affordable Care Act said we want to cover everyone. It actually excluded immigrants, but it basically said, other than immigrants, we want to get everyone covered. But if people already have health coverage that works for them, we want them to keep that. We want to give everyone a pathway to coverage. So the cheapest way that they could do that for the lower income groups in our country, so these are the working poor, was to say we're going to have about half of the uninsured people in our country covered through the Medicaid program, which is cheap. It's cheap, and it actually, there's already a system in every state. 38 states have said, yes, let's do that. Let me back up. So basically, that was the plan. The Supreme Court said, wait, you can't coerce states to take this on, and every governor has to say whether or not they're going to cover those people. So 38 states said we do. Tennessee's governor said he did, and the Tennessee legislature said, no, we don't. And their justification for that was they didn't like Obama. They didn't trust that the federal government would be a partner in the funding. Now, Medicaid has existed for 50 years. The federal government has always provided a lot of funding for healthcare. Healthcare is not something that goes away. If we don't fund it, it doesn't go away. It costs us whether we have federal funding or not.
Sure.
It's just that the question is the hospital going to be eating the cost? Are people going to be going bankrupt? Or are we going to leverage the federal money that is set aside specifically for Tennesseans or not? And I think there's lots of good ideas, and there's also just lots of exploring, but none of that is funded really. And there's not a whole lot of extra money sitting around the state budget, even in a thriving economy, to try these things out.
Now, the governor has allocated some money for some consultants to come in, a few $1 million, I believe, to help these rural hospitals find their way. Others have said that that pales in comparison to the federal government money that is sitting there. Is it helping or not, this money?
I mean, I think the problem is that Tennesseans, the number one issue that they voted in the last election was health care. That is what Tennesseans believe is the number one issue, and they want their leaders, this is both sides of the political aisle, we want our leaders to focus on this and solve it. So there's a lot of leaders now giving lip service to that, and I guess a little bit of money is better than no money, but the fact is it's $1.4 billion a year that could be brought to the state and could make a difference for the families that we're talking to all day, every day, and for the hospitals and the nurses and the janitors who are going without. I mean, I feel like sometimes there's lip service given. I don't know in the case of this specific thing, but sometimes there's a lot of lip service given to something that is clearly a priority for voters. And I just urge voters to keep saying, we want real solutions. We don't want lip service.
Let's say Medicaid does get passed here, the Medicaid expansion does. Does that mean the lights go back on at these rural hospitals and it's smart to continue operating the way they were?
Absolutely not. No, I mean,
what would need to change? That's what I'm trying to get to.
Yes.
What is broken? It can't just be one thing that was broken. So what is broken in the system?
Well, as Rebecca said, there's all sorts of complicating factors that makes it very challenging. And I think that the thought is the survival of the fittest model just doesn't work if a huge piece of the puzzle we are rejecting for political reasons. So I think some of these hospitals will have to close anyway. Not necessarily the ones that have already closed, or maybe some that that we don't currently know. But their hospitals need to be managed properly. They need to be listening to people in their community about the needs, and they need to have a mission that is actually moving the needle for keeping people healthier. Maybe some of them need to have inpatient services for opioid addiction, or turning into nursing homes so that people can be closer to their families when they get care that isn't that complicated but needs care. So there's an awful lot of need for reimagining the healthcare and the hospitals in our state, but we just seem like we have like a 30-pound weight on our leg.
Wheel, right?
So if we don't get the 30-pound weight off our leg, we really can't run the hurdles.
Move forward. Okay, let's go to Michael, who's hanging out on the line waiting for us. Hi, Michael. Thank you for your patience.
Hi, thank you. I have a question mainly for Rebecca. A number of rural hospital issues in Tennessee. We have one in our community, and just curious, what are some of the low-hanging fruit items that might be able to help our hospitals stay open?
Okay, great question.
Gosh, yes, there are a multitude of things that shifting towards population health is a big one.
What is that?
Keeping your community healthy and not accessing.
So being proactive in our
services.
Health.
And we see a lot of shift in payment from Medicare, and even Medicaid is shifting in their reimbursement of services here. And I think that this is a big movement that a lot of our rural communities are getting on board with and saying, let's not just provide sick care, let's provide well care. And let's educate our diabetic population on how to stay healthy and how to eat healthy and how to, if you have type 2 diabetes, get off of your insulin, move away from that. And that's the biggest strength, especially in our healthcare systems, that they can bring to the table, is treating wellness as a disease. Let's treat that as a disease instead of sickness.
Yeah. I like how Michael put it, that low-hanging fruit that's right there in front of our eyes, but until we're forced to acknowledge it, until the system breaks, that we just kind of go, we're just going to keep going on, we're just going to keep going on. Let's get to Donna on the line. Hi, Donna. Thanks for being part of the show tonight. Do you have a comment or question?
Yes.
Go ahead.
Yes. I have a comment. I know for a fact in Bledsoe County, where I have family, that Erlanger, actually in Chattanooga, took over the ER there and is furnishing the ER part of that hospital. The rest of the hospital's been turned into rehab and nursing home. So they can get ER care there and then get transferred. and also they have access like that. So maybe if some of the other big hospitals could help in those rural areas like that, it would be helpful.
You know, you bring up a great point. Are you all seeing success with this when some of the big corporations, the HCAs or the Vanderbilts, or come in and can eat up these smaller community hospitals and maybe make those transformations, or at least keep them afloat? It's not so much about one bottom line. Is that helping the cause?
Ascension helps. The Hickman County Hospital has been a huge success. Now St. Thomas here subsidizes that. So even though they're in the red year after year, St. Thomas is subsidizing that because of their charitable mission to make sure that that everyone has affordable, accessible health coverage. But Hickman County Hospital is a vital part of their community, and their ability to change lives and their ability to be employ these long-standing Hickman County residents is kind of amazing. And yet we're counting on that sort of charity instead of bringing in dollars to kind of help. I mean, I think that's a great thing, and I don't think that necessarily other hospitals' business model is about charity.
Yeah.
So then that's what their stockholders aren't counting on them to do charity. So I don't know. You may have ideas.
I feel like every hospital's bottom line depends a lot on charity care. I know within our rural hospitals in the state over the past year, they provide over $100 million of charity care. So every single hospital throughout Tennessee, throughout the nation, they all provide charity care. And I think that when it comes to caring for the citizens of any residents of any community, I don't know of one single person that has ever entered the healthcare workforce without a strong sense to serve.
True.
Physicians, nurse practitioners, CNAs, all the way down to the janitorial. I don't even mean it to say all the way down. Janitorial staff is actually way up there in my mind. But they all enter into that workforce to serve their community. And they want to take care of the people that need them. Bottom line. Doesn't matter what it pays, what the service might look like, that's what they're all there for.
Okay, let's get back to the lines before we have to take a quick break. We're going to get Phil here real quick. Hi, Phil. Go ahead with your comment or question. Phil, if you turn down that TV in the background, it'll make it easier, I promise. But you can go ahead. Okay, Phil.
Yes.
Okay, good.
Can you hear me?
Yeah, I sure can. Go ahead.
Okay. I just wanted to ask a question. I know Nashville is the #1 city in the area, and I was just wondering, has anyone ever looked into asking some of the multimillionaires and billionaires that live in the area, the musicians, things of that sort, to possibly contribute and maybe have a hospital named after them, and so they can help in the process of getting these hospitals back online?
It's
the cost that the young lady was talking about, the blue, was talking about in the Medicaid. Because see, when you say Medicaid, people automatically think poor. And the thing is that when you think about it, if you've been in the hospital before, and the aspirin will cost you $5, aspirins don't cost $5.
Right.
Is it possible that some of these people, just like you got, okay, just take for instance, top of my head, Oprah Winfrey. The lady has $100 million. She's a billionaire, or more than that, actually. Ask these people to, lend a hand, and help out and try to get things done. Because as you know, in healthcare, as well as the pharmacies and everything like that, it's very high, and people are not going to do a lot because they're trying to make money.
Yeah. At the end of the day, it is a business. Healthcare is a business now, and whether you turn to the stars to save the system, I don't know if that's going to happen across the nation or not. But at some point, just like you said, when you go to the hospital, an aspirin will cost you. I would say it's cheap if it costs you $5. It probably cost you $25. The system is broken on many, many, many levels. There's not one answer.
For sure.
Yeah. All right, we're going to take a quick break because I know that we have more calls to get to, more to discuss, so stay with us.